Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Welcome to Dialogue with a Doctor. This is a show where we interview physicians about their practice and what they do and their craft. We have Dr. Dan Wasserman. He's a practicing dermatologist here in Naples, Florida, and he's a very good one too. And we're going to be talking about skin cancer screening, but more education about skin cancer in general, which I understand we all need.
That's right. Thanks for having me. Skin cancer in this country has turned into a real epidemic. We were talking as we were walking up to the studio, we were talking about lung cancer and breast cancer. Skin cancer happens so frequently that they actually don't keep accurate statistics on it. It's felt that there's about 3 to 5 million skin cancers in the United States every year that are treated in a variety of ways. A lot of questions we often get are about what type of skin cancers are there, and I would say is that the most common types of skin cancers are basal cell skin cancers and squamous cell skin cancers, and they're about 95% of skin cancers. While melanomas gets the most press because they cause about 75% of skin cancer deaths. However, they are only 4% of skin cancers. And then there's 1% of skin cancer is made up of a lot of different types, and they're actually much worse than melanoma, so you never want to have those, but they happen so infrequently we don't make a strong public effort to educate about that. But with regards to skin cancer is that we're really at ground zero down here. So there's a couple of phases you could kind of think about when it comes to cancer development. First, there's initiation, right? So you're born and you start getting sun exposure. And as you accumulate the damage, particularly if you've had a lifetime of going to the Great Lakes in the summers, or the Finger Lakes in upstate New York, or Cape Cod in Massachusetts, you're accumulating that damage. And then what happens is you bring it down here in your retirement years, or in the next phase of your life, and it's like pouring gasoline on a fire. So people don't understand that there's that acceleration phase down here, and they have to really make a strong effort to protect themselves from the sun. With regards to skin cancer, it's the biggest problem is understanding the difference between treatment and protection, right? Sunscreens don't treat, okay? They protect, and they don't reverse, right? And it's all about moving through time more slowly with regards to the accumulation of that damage. Most importantly, it's important to understand how to use sunscreens down here in Florida most effectively. The question I get most often from patients is when they're coming in looking like burnt toast a little bit, they say, "Oh, well, doctor, I've been using sunscreen in the mornings. I don't understand what the problem is." And I have to have a long conversation with them that sunscreen doesn't last the whole day, okay? That there is I call it the 3 Qs. It's quality, quantity, and frequency, okay? So quality. So it's important to understand that that sunscreens are made up of lots of chemicals, sunscreens, and also physical sunscreens. The chemical sunscreens block a small spectrum of the UV wavelengths. So if you've thrown a lot of chemicals, you can get each part of the spectrum, and then sort of together they'll make an umbrella to protect the skin. While the physical sunscreens, they're dumb. I call them, they're dumb metals, okay? They don't know what wavelength it is. They're just a suit of armor. So if you think zinc and titanium, those are the metallic physical sunscreens. And that's like putting on a suit of armor, and they just kind of block everything. So most importantly, as I tell my patients, is to understand that you really kind of want a physical sunscreen for your sun protection. So zinc, preferably zinc, but also titanium is a good one. Those spray sunscreens, don't even bother. There are very few, if any, zinc spray sunscreens. And I see, particularly on the tennis courts, the people are applying it by spraying it out here and giving themselves a mist. That's doing nothing. So if the sunscreen really needs to go on like a spray paint, but I'll tell you right now, those spray sunscreens, if it's chemical sunscreen, they're useless.
So we're not doing it like hairspray?
No, exactly. It should be like spray paint, not hairspray.
And it's an inferior product is what you're saying.
Absolutely.
So just briefly, you were going a little fast there, which is good, but the chemical protection you were saying different wavelengths, that you see broad spectrum on bottles. That's what that means?
That's an excellent point. So a lot of people will ask me what the numbers mean, right? And it used to be that there was 30, there was like 15, 30, 45. Then what happened is they started making higher SPFs, all the way up to even like 70 or 100. But it's important to understand what the numbers mean, right? So if you're remotely good at math, an easy way to remember it is if you just take the number and turn it into a fraction, so 1 over the number, right? So let's make up an SPF of 2. So 1/2, right? Means 50% of the UV is getting through, okay? If you have an SPF of 30, that's roughly 1/33 or about 3%, right? So 97% is being protected, and about 3 1/3% is getting through. If you have an SPF of 50, you take 1 over 50, that's 2% getting through. And if you go all the way out to 100, it's 1 over 100, so it's 99% is getting through. Is being protected. 1% is getting through.
So less bang for the buck.
Exactly. So what the sunscreens companies were doing is how much they were charging you per ounce of this 50 sunscreen versus how much they were charging you per ounce of the 100s. It was a total marketing scam.
Mm-hmm.
So the FDA stepped in and said, you know what, the madness has to stop. And now you're just allowed to say SPF of 50 plus. Okay? However, the SPF refers only to UVB, okay? And UVB is only one part of the UV story. There's UVA as well. And the SPF has no relationship to the quality of sun protection against UVA. So what the FDA now said is, if you want to have UVA protection, you should say broad spectrum protection. So your question was, do you want the broad spectrum protection? The answer is absolutely, because that means you're getting both UVB and UVA protection. UVB is the sunny day. When we're having a cloudy day, we don't have much UVB, but the UVA wavelengths come right through the clouds. That's why down here in Florida, I think I got my first burn since moving down here, was that first cloudy day in about April came by, and I went to the beach with my kids, was doing some shelling on the beach, thought it was a terribly overcast day, and I sure enough got burnt on my back because the UVA was so strong through the clouds. So you need the broad spectrum protection. Absolutely. But here's an interesting fact about the SPF. So that brings me to my second Q, which is quantity. And this is where people make mistakes a lot. So there have been some scientific studies that have shown that the amount that they use for the testing to get the number on the sunscreen bottle is about 4 times the amount per square inch than an average person applies to their skin. So if you're applying an SPF of 50, you're really probably meaningfully applying an SPF of about 15 or 10. Okay?
Is that because people aren't putting it on heavy enough?
That's exactly right. They're not putting on heavy enough. So I don't try to convince my patients to say, hey, put 4 times as much as you're putting on. I don't do that. I say, listen, if you're doing 1 pump, do 2 pumps. If you're making 1 streak along the arm and rubbing it in, put 2 streaks. Okay, just try to double the amount.
More.
Yeah, just put on a little bit more. If you can double the amount you're putting on, that's probably going to make a significant difference in your sun protection.
We're going to take a quick timeout, and we'll be back to talk more with Dr. Wasserman about skin cancer protection, and we'll move on to more of that subject. We'll be back in a moment.
Thinking of buying a home located in a golf course community in the Naples, Marco, Bonita, or Estero, Florida? Here is what Mark Lai, former PGA winner, says about Realtor Michael York of the York Real Estate Group of Downing Fry Realty.
Hi, I'm Mark Lai. If you have any real estate needs in Naples, Florida, the one company to contact is the York Real Estate Group. Also, if you want a golf course property to invest in, Michael York of the York Real Estate Group is the guy to contact. Michael knows every golf course in Naples. I will tell you this, he's been in the golf business for a long time. He's played all the great golf courses down here, and he is an outstanding realtor. I've known him for quite some time, and he's he's got a lot of integrity, and he very much knows his stuff on all the different clubs here in Naples. So the York Real Estate Group is a great place to start. So if you have any time or anybody that wants to visit down here in Naples and look at the options out there, please contact the York Real Estate Group.
Welcome back to Dialogue with the Doctor. We're here with Dr. Daniel Wasserman, a practicing dermatologist in Naples, and we're talking about skin cancer screening, protection, etc. And we were talking about sun protection. And but first we want to talk about where Dr. Wasserman comes from and what his training is like, and tell us about that.
So I grew up in sort of what they call fringe rural of upstate New York. And that's actually an interesting point with where I grew up, because we didn't have a lot of sun. I think Syracuse was rated as the city with the second least amount of sunny days in a 365-day year. So you would think that I'm relatively protected. But there are two dogmas with regards to skin cancer, actually. And one is chronic accumulation of sun exposure and sun damage, and the other one is infrequent, high-intensity exposures, which is if you grew up in upstate New York and the sun came out, you closed your books, you went outside, you found the closest lawn you could find, and you just laid out. And that was just the way it worked. So I probably have suffered from the latter problem, not the more common chronic cumulative sun exposure. I then went to medical school in Philadelphia at Jefferson, did an internship at Stanford in California, spent 4 years in Boston training in dermatology at BU, Tufts, and Harvard. Spent a year and a half in Alabama perfecting Mohs surgery and a fellowship there, and then coming down to Naples, Florida.
Good. And where is your practice?
Right now we have a practice on Collier Boulevard, just south of 75. We're going to be having an office open, a small satellite office in Marco Island, as well as downtown Naples.
Very good. And I understand you have an associate as well.
Yes, I have an associate, Dr. Deborah Bailey, who has been practicing for about 20 years in Annapolis, Maryland, and I will be having a new associate join me in February, Dr. Anne-Marie Tremaine.
Very good. Well, let's pick up where we left off on skin cancer.
Yeah, so we were talking about how to use sunscreen, and we covered sunscreen with regards to quality, right? And you brought up an interesting question, was going to the store and being overwhelmed with all the products that are there. I kind of have a very easy rule of thumb to simplify it for my patients in terms of not getting too bogged down with brands. While it's true the cheaper brands are cheaper and don't work as well, an easy way to sift through all those shelves is to just say, okay, I really like Coppertone, and even though it's a cheaper one, I'm going to stick with Coppertone. So I tell patients, go to the baby formulation. If you go to the baby formulations of all the different brands, they tend to have less chemicals, more physical blocks, and higher level of protection, right? So I always say, if it's Neutrogena, if it's Coppertone, Banana Boat, CVS brand, go hone in on the baby formulations, and those will offer you some more protection.
It's counterintuitive.
Yeah, right. So I'd like to also talk about the last thing, which is I think the biggest error that patients make with their sunscreen, and that is with frequency. So we talked about quality, we talked about quantity, and I also like to talk about frequency. With regards to frequency, this is the statement I get from patients the most. Well, doc, I don't understand. I put it on in the morning, and I'm fine. I put it on in the morning. I'm protected. So where I grew up in upstate New York, that sunscreen probably is worth about 2.5 hours, maybe 3 hours of protection. But it's also like fuel in a car, right? The longer you run the car, the less fuel you're going to have, right? So what happens is you spend all that fuel. So as sunscreen sits on your skin, it's being actually spent and worn out by the sun that's interacting with it, okay? So I tell people is that you got to put it on every hour and a half to 2 hours, okay? Down here, it's intense. And here's the other issue that we have in Florida, is that there's lots of water. You have water on the golf course, you have water at the pool, you have water while you're boating, you have water in the puddles, you're walking around the lake in your neighborhood,
and
okay?
And you're sweating.
So what you're creating is you're walking around a mirror, okay? So actually the UV rays are going from the surface of the sun to your skin, and also from the surface of the sun to the water, and then bouncing up and hitting you, so you're getting pummeled. And so with that, we're actually getting, and the angle of sun because we're closer to the equator is actually more intense here. So we are actually expiring that sunscreen that's on our skin much more quickly. So I always say you got to put it on an hour and a half to 2 hours. If you're getting a tan, something's wrong. Yeah.
Got that.
The other thing is I get a lot of questions about is what are the treatments for skin cancer? So doc, you recommended Mohs surgery. Why did you recommend Mohs surgery? Can't we just scrape and burn it? Do I need a skin graft? What about radiation? Are there any other therapies? And so I'll make it very simple, and I'm actually going to run down the list of things that we do when we get a diagnosis of skin cancer, and I'll go from highest cure rate to lowest cure rate. The highest cure rate is Mohs surgery. It's a more labor-intensive procedure, not necessarily from the removal of the skin cancer, although there is a delicate and sophisticated manner in which we do that, but it's the processing of the tissue. So the question is, if we're going to cut out cancer, anything, you're going to cut out something from the skin, what happens to that? How does it get processed? If I take that piece of tissue and I send it to the lab, what they're going to do is they're going to do what's called bread loafing. So imagine I'm a human being and I'm as big as I am right now, and I take a bread loaf from the grocery store. What they do is they'll take that bread loaf and they'll take the equivalent of about maybe 7 to 10 Kleenex thin, paper thin, not the slices that we like to cut for sandwiches. We're talking paper Kleenex thin slices out of that bread loaf. And if that's a loaf of walnut bread, if you take 7 paper thin slices, you may not see any walnuts in those slices. So you think that there's no cancer in there and you got it all out. So in fact, they've done studies that show that bread loafing technique only checks about 5%, and some studies have shown less than 1% of the margins. Well, why is that even good enough? Well, the medical world deems that to be appropriate. So what Mohs surgery did is we said, okay, there's several circumstances where that's not simply good enough, okay? The face, the neck, circumstances where the skin cancer might have a more aggressive nature to it. Skin cancers that may not be more aggressive but are now much larger. Okay, so there might be some subclinical extension that we can't necessarily see. So rather than bread loafing it, I say we treat it like a FedEx package, right? I don't care what's inside the FedEx package. There can be all the cancer in that FedEx package that could possibly fit in there. What I do is, in Mohs surgery, when I'm doing Mohs surgery, is I take the box of that package and I unfold that box and I look at the entire surface of that package. If there's nothing on that surface, if there's nothing on the candy shell of that M&M, right, then I've got it all out. It doesn't matter what's in the middle. That means I've gotten around it and I've removed it. And so when we process that tissue, we're looking at 100% of the surface of that FedEx package. Okay?
That's pretty cool. That makes total sense. We're going to take another quick break, and we'll be back talk about more skin cancers.
Thinking of buying or selling a home in Naples, Marco, Bonita, or Estero, Florida? Think of the most experienced York Real Estate Group associated with the #1 brokerage in Naples, Downing Fry Realty, which produced $1.9 billion in sales in 2014, controlling 43% of all transactions in Naples. Jim, Michael, and Morgan York make up the York Real Estate Group of Downing Fry Realty. With over $250 million in sales transactions, they can offer you the expertise and trust you want and need in a realtor. Call them today at 239-273-6727 or visit their website, www.naplesyorkrealestate.com.
Welcome back. We're with Dr. Dan Wasserman, practicing dermatologist in Naples area. And we're talking about skin cancers, different type of skin cancer. We were just talking about Mohs surgery, and you talked about the margins. I'm not sure everybody knows what a margin is, but you could briefly touch
Sure.
on that?
Yeah, the margin is basically the border, okay? It's the edge of where we think the cancer is and where normal tissue begins. There are certain types of cancer. For instance, let's talk about melanoma for a brief moment. With melanoma, let's say I biopsy a melanoma and the biopsy report says I got it all out. Well, that's such a serious type of skin cancer that the risk of one cell breaking off and getting into the bloodstream that we didn't notice on the biopsy report is so significant, and the meaning of that is so significant, that even if we get it all out, we still have to take a rim of normal, or a sphere of normal tissue around it. I kind of tell patients it's like the insurance layer, the insurance layer, okay? We go around it and underneath it to make sure that not only did we just get it out, but and some.
In a pretty good size area.
Yeah. So melanoma scars tend to be longer for that reason. Bigger hole, bigger line, okay? Well, with basal cells and squamous cells, we know that all we have to do is be literally cells away from the margin, and that's good enough. That means we've cleared it. The risk of that leaching into the blood or the lymphatic system is much, much, much lower. Now, if we take it out and we see that it's in a nerve or in a blood vessel, that will change our treatment plan. But for most, over 90% of the time, all you have to do is go 1 or 2 cells out from that margin. And so it's very, or that border, and it's very important that if we're going to take a narrow margin and not do such a large insurance layer, that we want to be 100% certain that we got absolutely around it and underneath it.
Which is Mohs.
Which is the way Mohs surgery works, yeah. Mohs surgery is the only one that provides 100% margin control.
You were, before we got on camera, you were talking about something I hadn't thought about. Patients, when they have a second basal cell, don't understand why they got it back. Can you speak to that?
Yes, so our skin is a canvas, right? And we didn't get sun exposure on this spot. We got sun exposure on this whole area. So there are some interesting statistics with skin cancer. Once you've had one skin cancer, you have a 15% chance of getting another one anywhere, not it coming back, but anywhere on your body within the first year. 35% chance within 3 years, 50% chance within 5 years. And if you've had a second skin cancer, you have an 80% chance of getting a third. So some of my Irish patients have told me that they call it their Irish acne, okay? Because of their fair skin and their susceptibility to some damage is much higher, and their ethnicity. So it becomes a chronic problem. And that's why I encourage my patients, and I would encourage any of the people listening at home, is to have conversations with their dermatologist about how to improve the organ, right? And I'm always having the conversation every day. Every other patient, I'm giving them the analogy, it's like pulling weeds. We can pull weeds all day, but we got to treat the lawn, right? And if we don't treat the lawn, we're just going to be a hamster in a wheel, right? And we're going to be going through this over and over again. And as you get older and your immune system starts to tank just from age, and you're getting more sun exposure, the number of skin cancers you're going to get per year is just going to go up and up and up. And it's just going to be exhausting, okay? So there are lots of treatments that we can actually do that will actually treat the lawn, okay? We call those field therapies. There's topical chemotherapy. There's a variety of pharmacologic agents that we will apply to a skin, to an area that will cause a bad rash. That rash is actually therapeutic. So I always tell patients, the worse the rash, the better it's working. There are light procedures that we can do that'll also treat the skin, that may treat smaller, earlier skin cancers. So you have the option of treating the skin that has problems that we can't see yet, pre-cancers and skin cancers. So it's very important that you look at the skin as an organ, not as a canvas of symptoms, and that we treat and not only do we treat the symptoms, but we try to improve and fix the problem.
So the rash that you're causing is really you're destroying a layer of skin.
I wouldn't call it a layer, but I would call it you're destroying the problematic cells. And if your whole face has been exposed to the sun, guess what? Your whole face has probably got some problems with it with regards to sun damage.
I see. So it is a chemotherapy that will kill a cancer cell more than it will kill a regular cell.
More is the right word. Yes.
More.
Yeah.
Okay. So how often do you, in your practice, see skin cancer?
A day?
10% of your patients, or?
Percent of patients, I don't know, but I would say, you know, in my practice, just me alone, I am seeing probably close to 1,000 skin cancers a year.
Okay.
And if you think about the time I'm spent treating the skin cancers, is probably about 40% of my week. The other 60% of my week, or half of my week, is the portion diagnosing it. So I'm diagnosing about, only half of my time is spent diagnosing skin cancers, and I'm getting about 1,000 a year. That's a lot of skin cancer in my practice.
That is quite a bit. And you do Mohs surgery?
I do.
Yeah.
Yes, sir.
In your office?
Yes, sir. And that's the advantage of Mohs surgery. You don't need general anesthesia. It's done under local. Patients are awake speaking to us. We talk to them about their family. We listen to whatever music they would like to listen to. And they don't run the risk of the complications of general anesthesia. They don't have the fees with facility fees or surgery centers, and everything gets done right there in the office, 99% of the time.
Well, that's very convenient. And your samples go to a pathologist when?
So the definition of Mohs surgery is that the surgeon is both the surgeon and the pathologist. By definition, so if someone says they're doing Mohs surgery and they're sending the tissue out, that is in fact not Mohs surgery.
Okay, I didn't quite realize that.
Yep.
That makes total sense. So you're examining the specimens in
That's
your
a legal
office.
definition, actually, both with insurance.
Oh.
Yeah. So
Wow.
yeah.
Yeah. Ideally, you don't want to do any Mohs surgery, but there's no lack of patients to work on.
Right.
Well, we really appreciate you being here. Actually, we welcome you back because you talked to us before, and we also would like you to come back in the future.
Thanks very much. I enjoyed it. Yeah.
We learned quite a bit, and I'm sure our audience did as well. Thank you.